Yeah, thanks a lot. Also for me, a great pleasure to be here in this beautiful setting at the World Surgery Tour, and of course an honor to perform something like a double-level osteotomy together with such an experienced colleague. So Kristian's pretty much going to take us to this area where we still have a slight varus deformity, and I'll try to close the loop and do the rest of the way by performing a high tibial osteotomy. My hinge position will be somewhere around here, about 1 centimeter underneath the joint line, 1 centimeter from the lateral cortex, pointing towards the fibula head, without hinge fractures, of course, and we do it in a biplanar way, so we neutralize the slope as well. Same publication from the Operative Orthopedics Journal, this time from Philip Niemeyer. This is pretty much what we're going to do. We do a vertical incision bit at the top of the pes anserinus, dissect the periosteum, go underneath the medial collateral ligament. As we all know, we need the release of the medial collateral ligament, and afterwards perform our osteotomy in a biplanar way. So there we got the ascending osteotomy beyond the ligament and patella. You can do it in a descending way as well, but this time we stay with the typical ascending biplanar high tibial osteotomy. And as we all know, it's all about planning your operation and operating your plan. So this is what my part is supposed to look like at the very end, with Kristian's plate on top as we're performing a double-level osteotomy. And let's see what we can get out of it.
Gerrit, thank you very much. The HTO, as you mentioned it, maybe you can just stay for a minute longer, is somehow the working horse. So main of the procedures will be the HTO. Can you explain us when do you switch for a double-level osteotomy? Are there any borders, any extremity values where you go for?
Yeah, first of all, it's about detecting the location of the pathology. So when it's a femoral pathology, you have to correct it in the femur. When it's a tibial, you have to correct it in the tibia. And then it's about not to overcorrect in the specific bone. So from the medial proximal tibial angle, we try to stay at an angle lower than 93 degrees in order not to end up in a pathologic joint line, just as he explained.
So 93 degrees is your personal limit somehow?
Yeah, pretty much.
Yeah, okay, perfect. Maybe we can discuss this limit later on, and I want to thank the company NewClip for supporting us with the plates during the operation, and maybe Gerrit, you can just say some words to the different plate designs.
Yeah, we got a quite nice portfolio of several plates for the femur. This would be the common femoral plate, which we're going to use right now. There's a new one for the correction of the femoral torsion. So you got a descending leg screw to avoid hinge fractures as well. In my part, we'll use this plate for the high tibial osteotomy with 4 proximal and 4 distal angular screws. It's like the working horse in my OR. You can have it in a shorter way with 3 screws as well, but for the biplanar one, this is the typical one. And if you end up doing ACL revision cases, you will also end up doing slope corrections, and this is quite a nice plate, especially for the slope correction with an leg screw included inside the plate, so it's very easy to close up the slope. So you got a huge portfolio of several plates you can choose from and adapt it to what your patient needs.
Thank you. I suggest then we just switch over to the stage to Kristian and see what he's doing.
Thank you so much. So we are here and actually have a very nice specimen. It's not too big. It's rather the size of an arm, which makes it tricky to fiddle around with the plates. But nonetheless, we will guide you through this. So let's have the view from over my shoulder, please. And that's what I always do. I draw the landmarks and have the lateral epicondyle here. And the interphalangeal part of my thumb actually just goes to the condyle, rolls down. I grab over with my index, and in between my fingers, I just draw a line. This is my incision for the distal femoral osteotomy. For the sake of this presentation, obviously, we make it a bit bigger, okay? So that would be the incision.